All right. Well, good morning, everyone. It's my distinct pleasure to introduce Dr. Carlton Eduardo Corrales as our grand round speaker this morning. Dr. Corrales is an assistant professor in the Department of Otolaryngology, Head and Neck Surgery at Harvard Medical School. He serves as section chief of otology, neurotology, and skull-based surgery at the Brigham and Women's Hospital. And he completed his medical school at the Autonomous University of Honduras and went on to complete his residency and fellowship at Stanford. He knows many of the faculty in our department and has wonderful stories. And we were just catching up about that. And thank you for sharing that. He has a broad expertise. He's published broadly on diseases of the ear, including otosclerosis, stapes, SSCD, and vestibular schwannoma. Notably, and most excitingly, he's been involved in leading pioneering work for novel inner ear gene therapy, specifically a phase 1/2 clinical trial for otopharyngeal-related hearing loss in association with decibel therapeutics recently required by Regeneron. So today, Dr. Eduardo Corrales will be providing an update on the latest developments in this trial. And we thank you so much for being here, Dr. Corrales. We are so excited to hear about your presentation. Thank you very much.
Thank you so much, Michael. It is a pleasure. I really want to thank all the residents, including Michael, for the invitation. I also really want to thank Song and Nikki for, spending time with us here in Boston. It was an enormous pleasure to train you guys, and hopefully you're doing great. So I will be talking about the clinical trial DB-OTO. It's a therapy that's in pediatric patients with profound hearing loss, and these patients have otoferlin mutations. It's a phase 1/2. Let me see if this works. So I am an active employee and shareholder of Regeneron Pharmaceuticals. I also received other grants from local and regional grant societies. So the first thing I want to start off is, this is our classical fellowship here in Boston. We kind of have great food, great beer, great wine. As you can see, you probably know Dr. Naples. He told me that he gave you grand rounds a few weeks ago. You can see in pink here, that's Johan. He's now a neurotologist in Atlanta. And you can see Song, and this is the Song I know with just a t-shirt. I'm not sure if UCSF has ruined him to suits and all that, but you can see this is a classical, beautiful summer day, and it's always like this. Actually, that's not entirely true. This is my 6-year-old daughter. 2 days ago, we got a storm and she's doing her classical angels. But this is Song, as you can see here, he does dress up ever so often to conferences. This is in the photo right at Harvard Medical School, just behind the hospital at Brigham and Women's Hospital. And you can see Song. This was an invited guest of Dr. Pascal Sen from Switzerland, the chair at Geneva. But Nikki is a whole different level now. I could tell you, Dr. Yam, she's very proper, dresses beautifully. So for her, we had to bring out everything. As you can see, this is in our house. We had a great barbecue evening, but Nikki was proper always. So I had to, get all the fancy stuff out, etc. And you guys know Abel right here on the left. He's our second year fellow now, and he's looking to, sell his soul to a department. So anyways, I really want to thank you all for the invitation. So I'm going to give you a little bit of the clinical presentation, pathophysiology, and diagnosis of patients with otoferlin. When we talk about patients with otoferlin, we think about prelingual hearing loss, that 80% of it is genetically encoded, 20% is acquired environmental. When we focus on this 80% of genetic hearing loss, we then split this up into 70-30, 70 non-syndromic, 30 syndromic. And when we focus on the non-syndromic, you have 80% of those are autosomal recessive, 19% dominant, and a few less than 1% is mitochondrial. And as you guys know, especially for the residents, non-syndromic means that there's no other congenital differences or any other issues with the patient. Syndromic means that there's other differences within the patient. And so far, Cynthia Morton here at Brigham and Women's at Harvard has really good studies about over 500 distinct genetic syndromes included. Otoferlin falls into this recessive pool. And when we talk about this recessive pool of patients, 80% of the non-syndromic, we tend to think about the connexin family, especially GJB2 and GJB6. Less so of otoferlin. Depending on the studies that you look, it could be 1.4 to 3.2%. As discussed, 120 non-syndromic genes have been identified to date. And clearly, GJB2 is the most common cause of non-syndromic hearing loss. The two proteins that are common are the 26 and connexin 30. When we really talk about connexin testing, we really refer to GJB2 and GJB6. When we discuss otoferlin or deafness B9, we're talking about non-syndromic autosomal recessive. These patients present with prelingual auditory neuropathy spectral disorder, or ANSD. What does that mean? When patients present, when they come to our clinic and they have these otoferlin mutations and present with auditory neuropathy spectral disease, we talk about auditory brainstem responses and distortion product otoacoustic emissions. And for the residents, again, it's very important to know this. You will get asked this over and over. In patients with auditory neuropathy, auditory brainstem responses are absent. As you can see here on the left of the screen, otoferlin patient on the right, and otoferlin patient tested with the left ear. And you can see it's a flat line. You don't have the typical waves of 1, 3, and 5. And so when we look at distortion product otoacoustic emission, this is the one that tests the outer hair cell function. So ABR is a good indirect correlate of the inner hair cells. Distortion products is for the outer hair cells. And as you can see in patients, they have normal distortion product otoacoustic emission. And so where is this otoferlin? What do we know about otoferlin? So if we look at the inner hair cell within the cochlea, at the basal part of this inner hair cell are the synaptic vesicles. Within the synaptic vesicles, you have the neurotransmitter. As you can see here in blue, the otoferlin literally needs to tether this synaptic vesicle to the membrane. So when we have otoferlin, synaptic contact with the membrane, you have release of the neurotransmitter. That's what we know. There's a lot of other functions that we attribute to that, but that's the main one. And so when we don't have otoferlin protein produced, then we know that this neurotransmitter stays within the vesicle. There's no tethering to the membrane, and thus there's no neurotransmission. When we look at patients who present with otoferlin deficiency, we know that 95% of these patients present with profound hearing loss. We have collaborated with Ignacio del Castillo in Spain, who's an amazing geneticist, and he's probably amassed the most comprehensive database of otoferlin patients. And what we know that if we classify these patients by their audiogram, we know that over 95, they're severe to profound hearing loss. And if we look at natural studies of patients with otoferlin, we can see that if we divide this by decades of treatment of otoferlin patients, we see that in 1990 to 1999, we had very few patients with bilateral cochlear implantations. We were putting a lot of unilaterals, and a lot of them were getting untreated. As we see the decades, we progress in the amount of bilaterals that we place. Still, the vast majority are unilateral, and very few are getting no cochlear implants. As we move into the last decade, you can see that the vast majority of them are getting bilateral cochlear implantation. And if we see the age of implantation of these patients, you see by the same decades that on average from 1990 to 1999, children were 6.3 years of age when they got their implant. Move a decade later, this was slashed in half to 3.4. And what we're currently seeing right now is approximately 1.2 to 1.6. So try to get these patients within a year or around that year. So I'm going to describe what we've been developing, like Michael said, initially at Decibels, which then got acquired by Regeneron. It's a first-in-human gene therapy trial. And on a very superficial, simplistic view, you have an AAV. This AAV virus has a cargo capacity, okay? When we fill this AAV with a gene, a corrected gene, we want to make sure that it infects the cell of interest, in this case, our inner hair cell. Once within the inner hair cell, we want to make sure that this virus is translocated into the inner ear nucleus and then does a recombination. Now, you might ask, you can see that I have two viruses here, a blue and a pink. It turns out that the AAV virus that we're using doesn't have enough storage capacity to put the whole gene, the corrected gene. So we basically break off the corrected gene, put a little piece within the blue virus, put a little piece in the pink virus, and they get translocated into the nucleus. They have hairpin recombination technology, and then they start producing the otoferlin protein. When we look the mouse model that we use, called Q828X, a heterozygous mouse, you can see that has all the expression of all the hair cells, including the inner hair cells and the spiral ganglion cells, and you can get good wave patterns of auditory brainstem responses. This is a K828X untreated and homozygous mice that doesn't have any fluorescent expression within this. So within Decibel, now Regeneron, we developed this dual AAV1 system where it's the inner hair cells are infected, specifically the inner hair cells with a myosin promoter. We then see expression of these mice and restoration of the auditory brainstem responses. Now, the first one that really did these elegant experiments was Dr. Larry Lustig, as you guys know from UCSF. He, a few years ago, published a really nice article detailing hearing restoration using a very similar type of mouse model. So, literally, the goal of the clinical trial is to provide durable, high-quality hearing. We identify the patients through a routine newborn hearing screen, and we do otoferlin genetic testing. We have a good sense of the amount of patients per year that are diagnosed with otoferlin. We think that it's between 20 to 50. There are reports that it's slightly higher. There are also reports slightly lower. We did get approval from the FDA for an orphan drug designation and from the European Union. And so both the FDA, the MHRA in England, and the EMS, Agencia Española from Spain, cleared it. And so, as you are aware, we're not the only, a game in town. There are other companies that have other technologies that are having really good results as well. And so we've developed a lot of clinical sites within the United States, Europe, and as well in the UK. And so it's a global first in human phase 1/2 of DB-OTO in infants. And we have already enrolled, which I'm going to show you the data today, within the United States, the UK, and Spain. Here is the inclusion criteria. Patients need to be less than 18 years of age, infants less than 2 years of age, or 9 months in the United States. This has recently changed. They have cleared us to now dose because of the good results in Europe. It is staggered by age in the United States. That's also not current anymore. And within the UK and Spain, it's less than 18 years of age, so no adults yet. They need to have the presence of 2 pathogenic otoferlin mutation variants. They must have profound hearing loss, and they must have distortion product otoacoustic emissions or cochlear microphonics in over 2 years of age. The way we designed the trial is that part A, we have a unilateral dose escalation to see, remember, phase 1/2 is all about safety. And part B is a bilateral expansion with selected doses. Again, it's about safety, tolerability, and efficacy of the trial. This is kind of like the standard timeline of the trial. We do a lot of baseline assessments for, to make sure they meet all the criteria. We do safety screen, clinical evaluation, and all the tests that we just spoke about. Day 0 is the day of surgery. So I have attended all the deliveries globally, and that is our day 1. We do give the patient postoperative antibiotics and corticosteroids for the first 2 weeks, and then taper after that. And then it's a battery of assessments that will follow up to 3.5 years. And so for a total of over 5 years that the FDA required. And that's just the clinical trial timeline. In terms of how we get the gene therapy in, anybody who can actually do a cochlear implant can actually do this. You don't need a novel device. If you can do a cochlear implant, you can do this gene therapy. And so you do a classical post-auricular incision, and You drill a cortical mastectomy with identification of the antrum, the lateral semicircular canal, and then you open up the facial recess with the chorda tympani anteriorly, descending segment of the facial nerve posteriorly with the incudal buttress superiorly. And once you have a good identification of the round window niche, not similar to a cochlear implant, if you have to drill on the overhang, you will drill it. And so then so that's the surgery. It's all very standard for cochlear implantation. There are literally two differences now after identification of the round window membrane. We do create a fenestration within the lateral semicircular canal of approximately 0.5 to 0.6 millimeters. And then we use a catheter to, to introduce our gene therapy. To get the catheter in, you use a standard straight pick or a Rosen needle to open up the round window membrane in a snug manner. Catheter goes in 3 to 4 millimeters, and you literally just let the catheter go. The catheter is connected to an infusion pump. The infusion takes approximately 15 minutes, and then with a pause of 5 minutes. So a total of 21 minutes. And as you can see here on the right, the whole purpose is that we do a full perfusion of the cochlea, where we're perfusing everything through the perilymph, where it connects into the helicotrema at the apex, and then it leaves into the vestibule and into the lateral semicircular canal. And I'm going to show you some really cool data of the first patients. These are the first 5 patients that we have dosed. You can see, I'm going to show you all the information of patient 1 because it's the one we've had the longest follow-up now. Patient 1 was 10 months of age. She had a cochlear implant at the same time as a gene therapy for backup. She had all patients had distortion product. All of them had pathogenic otoferlin mutations. This is the dose that they received, and the surgery delivery was completely uneventful. And as you can see, it ranges from 10 months, 4 years, 15 months, 25 months, and 4 years. And so when we talk about phase 1, 2, we talk about SAEs, or serious adverse events. And here are the 5 patients. It's a little busy slide, but what you want to realize is that in patient 1, right here, it's the only serious adverse event that we've had so far. This is the patient, our very first patient. She developed, by criteria, mastoiditis in the contralateral gene therapy. So on the cochlear implant side, this patient received right-sided gene therapy and a left-sided cochlear implantation. So on the left side, she developed mastoiditis that required 2 days of admission for antibiotics, and she's doing great. You know, there's a lot of talk of a vestibular issues, injury, because we are opening up the lateral semicircular canal. And as you can see, patient 3 and patient 5 developed transient nystagmus that really resolved within the first week. And so far, we haven't seen anything in patient 1, 2, or 4, and we haven't seen any inflammatory immune issues so far. And so let me tell you a little bit about Opal. That's her name. And we know that her name is Opal because the BBC published a really nice article on Opal. And so when we met her, it was an 8-month-old female, and she had bilateral profound hearing loss and presented with auditory neuropathy. ABR absent, distortion product acoustic were present, and she had otoferlin mutation. So she was enrolled. You can see the genetic mutation that she had. What's interesting with Opal is that she has an older sister who is bilaterally implanted, who also had otoferlin. So the family was very in tune about the otoferlin mutation, and her older sister has bilateral cochlear implant and is doing great. So the parents elected to do a cochlear implant on the left and the gene therapy on the right. So at the age of 10, we did, I was there to support the surgery. We did her surgery. We, at the usual standard dose, cleared by the FDA, and a cochlear implant was placed in the last year. The patient received antibiotics and steroids per protocol, and the perioperative period was uneventful, and the patient was discharged on post-op day number 1. And this is the first highlight slide that I really want you to focus. This is Opal's trajectory up to week 48. You can see that this is testing done in her right ear only, the gene therapy ear only, and obviously without the cochlear implant used. And so you can see that her baseline was profound hearing loss. By week 4, she started to get some responses, okay? And obviously, these are pure tones. By week 12, she was already in the moderate category. By week 24, you can see that she is now in the mild to moderate, I'm sorry, mild to normal category. Opal, as a lot of kids do, she developed a otitis media that required ventilation tube placement, as you can see here with the conductive component. And then once the tubes went in, she went back up. Opal did have this drop at a higher frequencies that we really don't know why it dropped, but we're continuing to measure her in terms of that. So this is Opal at a normal to mild level. And I want to show you again on the right side, you'll see Opal's baseline audiogram and at week 24. So what you're going to see is a video here, and I want you to really focus on what the parents, this is mom, and this is dad, and this is Opal. Remember, Opal received a right-sided gene therapy trial of DB-OTO and on the left cochlear implant. This is Opal without her cochlear implant. And in a very British, thick British accent, you will see that the mom says, blow me a kiss. And she actually can understand mom and blow a kiss.
Mommy kiss?
Okay. And that's very impressive. But then parents started noticing music appreciation. And then if you look over here, this is her stuffy with an empty plate and a glass, and this is her sister. And look at this.
Can you give Snap Snap a big cuddle? Yeah, give him a big cuddle. Can you give Snap Snap a kiss? Yeah, can you give her a kiss?
That's her sister.
Snap Snap is hungry. Yeah, he's hungry. What should we do? Oh, yeah, yeah. Snap Snap would like some hot chocolate. Can you give Snap Snap a drink?
Which was phenomenal. And then when we look at trying to figure out words and pinpoint to the meaning of the words, I want you to focus on this video.
Where is the duck? Good girl. Can you show me again? Where's the duck? Which one? Good girl. What noise does a duck make?
What does it make? Does it make quack?
Quack, quack, good girl. Where is the ball? Show me. Good girl.
So she is now able to recognize sound into words. When we do formal testing on Opal and open and close set tasks, she was able to identify 70% of the words. And again, this is on her right unilateral gene therapy trial without the cochlear implant. And as you could see at visit 44, at visit week 48, she was able to identify 7 out of 10 words. And the words that she missed were puppy, cheese, and mouth. And apparently, according to the parents, they don't use the word puppy in England. And so I'm going to say that this is the first in-human experience of DB-OTO. It is an AAV1 dual vector system that we are able to deliver through the cochlea, a full corrected length of the otoferlin gene. And we've treated 5 patients so far. And we have all seen significant improvements. In the first 5 patients so far, the delivery and postoperative periods were completely uneventful. DB-OTO was well tolerated. with really no adverse events or serious adverse events in terms of safety. As we alluded, Opal did get mastoiditis on the cochlear implant side. In the first patient treated up to 48 weeks, there was clinically meaningful improvements of DB-OTO across tested frequencies. No ABR or PTA response was observed in the contralateral ear, obviously in the cochlear implant side. Formal speech perception testing without a device was measured at 22 months of age, and preliminary results are very encouraging and are corroborated by the family's observation. In fact, the family relates that Opal, whenever she takes off her cochlear implant on the left, her voice changes to a more natural sounding voice. And it's pretty impressive to hear that, right? When you start to think about how important cochlear implants have been for the last decades, having a mom who is well versed in her first daughter with bilateral cochlear implantations, to have Opal take her cochlear implant out and have a more natural sound pronunciation is really remarkable. In addition to the 4 patients dosed so far, no safety concerns have been observed. Obviously, we are enrolling currently, and we have sites in the United States as well as in Europe. And I'm going to leave it there. I really want to thank the families who have trusted the science initially of Decibel and Regeneron, but also all the PIs who actually believed in the science that we have. It's probably been over 10 years now working on this project. For me, as a otologist, neurotologist, and skull-based surgeon, I started with Decibel in 2015 with various projects, including this one. And it's just really nice to see the fruits now. It's impressive to be in the operating room with these babies and seeing the perfusion within the inner ear. And so I know I'm happy to answer any questions. Again, I really want to thank you guys for the invitation. Happy to answer any questions.
Thank you so much, Dr. Cross. Very exciting work, and I'm sure we'll have many questions. I would love to kick us off for quickly, and I see that Dr. Rosen has a quick question, and we have many others from the group. So Dr. Cross, I'd love to hear about kind of currently where things stand with how many subjects are enrolled, what sort of impacts you've seen, what can you share with us? And then I think we'll kind of go by a call of hands. We have Dr. Rosen, and then I'll sequentially call on people as they raise their hand, if that's okay with you.
Yeah, it's a great question, Michael. So we are currently enrolling, and I have been very vocal within the company that we should be presenting as transparent as possible all our data. We want all the pediatric otolaryngologists, all the otologists to see the data and comment on the data so we can make a better clinical trial. So we're currently enrolling, and as you can imagine, once we presented this data, we have been inundated with centers from across the world in terms of enrolling patients. And we have a long list right now, which is a good problem to have. And hopefully in the coming months, we'll be able to divulge a little bit more in terms of the total number of patients that we've dosed.
Thank you so much. Dr. Rosen, I was asking, have other subjects received CIs as well?
So because of the data, this is, again, you got to change now your mental pattern of thinking. It was a Spanish mom who literally looked, because we share the data with the parents, and the mom, super educated, well educated, said, I see that you implanted the contralateral ear, but I don't want an implant anymore. I really want bilateral. And we were not cleared to do bilateral at that time. And so she said, okay, I'm happy to wait for my daughter until you guys get approval. It just blew us away, but it also made us think about sequential dosing. So at Regeneron, we have a vested interest in studying sequential dosing in patients, and we're actively studying this at this moment. And Dr. Rosen, does that answer your question? What was the question again?
Have other subjects received CIs as well? Like
So,
in addition.
so to answer your question, only the first two have received concomitant cochlear implants in our trial.
Thank you so much. Okay, I think we have Dr. Dylan Chan next.
Hey, Eduardo, thanks so much for coming and speaking. So awesome to see
Absolutely,
you.
Dylan.
Yeah,
Good to hear from you. How's it
yeah,
going?
excellent, excellent.
Good.
Yeah, such an exciting time.
It is. I agree with you. It is.
Yeah. So I'm curious. Have you guys seen some variability in results like the other companies have? And for the kids that sort of end up in the mild to moderate hearing loss range, are they generally getting hearing aids for those years?
So that is a great question. So this was brought up at multiple meetings now
Yeah.
that we should never forget the rehabilitation options for kids that end up in the mild to moderate category. So we are constantly encouraging the patient's families to go ahead with this. And then we are seeing variability, Dylan. There's no question about it. And it's very different from the other companies. And but one of the things that we do have in similar is that we do get an improvement with all the patients. However, the trajectory to get there is very different,
Hmm.
right? And so there's a group that has reported on earlier recovery, way faster than what we have. And but it's just a little bit of a few weeks in terms of
Hmm.
that. And obviously the technology that they use is slightly different.
Right.
But they've also reported delayed in some of their patients. And so there is variability in that sense, in terms of how fast they improve to what level they improve, right? And our data is very similar in that sense that I wish all of the patients were like Opal, right? Where they're
Hmm.
going, to the best possible normal category. But we see some patients, the other part that's very interesting, and we've been, very transparent about this, is that we're seeing a very interesting phenomenon. As an otologist, I always thought that if you do a cochlear implant as soon as possible, they're going to get better results. That's been our thinking for decades. It turns out that for whatever reason, we're seeing that the older patients are recovering faster and they're holding the recovery better. I'm not sure if it has to do with maturity of the inner ear.
Mhm.
We just don't know. And we're looking into this as well. So there is a lot of variability like this.
Cool, thanks.
Yeah, absolutely, Dylan.
Thank you, Dr. Chan. We have Dr. Nicole Jim next.
Good morning, Eduardo. It's so good to see you.
Nikki, good to see you.
Thank you so much for a fantastic talk. I was wondering, how are you currently counseling your patients, both pediatric and adults, about cochlear implants and the possibilities on the horizon?
So that is a great question. I can tell you that patients, especially in New England, are very educated. They have found my name associated with Regeneron, and they come in saying, I want gene therapy. I probably have more than 10 patients that have come in, Doc, I'm just here for the gene therapy. And I do feel that this is moving at a rapid pace. As our pipeline includes GJB2 as well, which is a more frequent mutation. And other companies are working on other mutations as well. I do feel that in the next 5 to 10 years, we are going to be at a different spot in terms of counseling patients. At this moment, for adults, I'm literally saying get the cochlear implant, right? I don't think, more studies are coming out now that, what we typically call presbycusis is actually not presbycusis. It's delayed fashion genetically encoded hearing loss. And there's been a lot of studies coming out from the UK and Spain that, what we normally attributed presbycusis as age-related hearing loss is in fact a genetically encoded. However, to try to figure this out is a little bit more complex. And so for adults, I'm literally telling them, get a cochlear implant. If I were in your shoes, I'd get a cochlear implant. That is very different from the pediatric population, right? If I had a daughter with otoferlin, at this moment in time, it would be absolutely crazy to put a cochlear implant in, with the results not of only Regeneron, but every single company has reported hearing improvement, every single one, right? And so if I had a pediatric patient now with GJB2, and I would probably counsel the patient's family and say, look, there are a lot of therapies in the horizon with this. And if you can tolerate getting a one cochlear implant, you could do that so the kid doesn't fall behind, right? And who knows what the future will bring, right? But from the pediatric standpoint, it has changed my mental thinking and counseling.
Thank you.
Yeah.
Thank you, Dr. Jim. I think we have Dr. Anna Meyer next.
Hi, great talk. It's been very interesting. I've had the privilege of being on the trajectory with one patient who was had therapy at CHOP, and she was implanted in one ear because she was too young to be in the trial when it was still in the early stages. So she had gene therapy at 4. And I just got her audiogram from the most recent testing, and she's in the normal range pretty much across the board, 30 dB in a couple frequencies, but
Yeah.
it's pretty incredible. Interestingly, she has her OAEs in her implanted ear still, even after because we did an implant when she was about a year old.
Yeah.
And the family, I mean, the debate we have is like, will there be a time, do you think, I know it's a different company, but like, will there be a time where you might, if they have retained their OAEs, do the gene therapy in the implanted ear, how you might handle that? Like, I can't imagine pulling the implant out to do it. Would you just do it around the implant? Like, it's just really interesting to consider. It's amazing too that she's 4.5, and she really can tell us at length about the experience of each ear and the differences. And she's named them after Frozen. One is Anna and one is Elsa.
That's awesome.
Interestingly, my first name is Anna, but that's not the implant ear that I did.
Well, these conversations we have had over and over at the company, and there is a lot to discuss about perfusing an inner ear that has had a cochlear implant, from preserving the basilar membrane with the organ of Corti, which you require, to the development of fibrosis within, the scala tympani. There's a lot of variables that go into a cochlear implant within the inner ear. And there have been many talks about, and we've had patients say, are you okay taking out the cochlear implant and perfusing my daughter's ear? And I don't think we're there. I don't think we have enough of the knowledge to do that. And the problem with that is that, if you do decide to take the implant in and something happens where somehow the gene therapy doesn't work, you might lose the ability to get that implant in again and have similar outcomes as before removal. But it has been contemplated, and we've had families already ask about that.
Thank you so
Thank
much,
you.
Dr. Meyer. We have Dr. Schroen next.
Hey, thanks for an awesome talk, and congratulations on all the amazing work that's been done. If I might, I have 2 questions. One is, so we have 3 companies, unless I missed one, who are studying otoferlin as kind of the first target. And I understand there's a number of reasons for that. I was curious what you thought the next otoferlin would be. And you mentioned Connexin 26 and doing gene therapy for that. I was hoping you could talk a little bit about the challenges of Connexin 26 as compared to otoferlin, and why it might take another 5 or 10 years. And the second question is just looking over the method of delivery with the lateral canal fenestration and seeing some nystagmus in the post-op period. Has there been any follow-up vestibular testing on those patients, and were any permanent deficits noted?
Excellent questions, Dr. Sharon. So let me answer the second question first. So we have vestibular testing in all our patients. So in the postoperative period, they get CVAMs and they get some clinical outcome vestibular testing. And so far, the testing has showed stable responses. And so that's the first thing. So this was something that I was very gung-ho that we needed to do this test to learn more about what we're doing, but also to prove that we're not causing permanent damage. We don't cause any permanent damage with this. So that's the second question. The first question is a very interesting question. As you know, I started talking in my presentation, it's the most common mutation, right? So for a company, the market is there. Now, when you start to stratify patients with GJB2, you have a full spectrum, as you know. You have, patients who have a mutation and they are in the mild to moderate category, and some of them that are profoundly deaf. When we look at otoferlin in the profoundly deaf GJB2, that's kind of like an easy answer, right? Because they really don't have much to lose. Where it gets really tricky is how are we going to counsel our patients, our parents of our patients, to say, well, you have a mild to moderate, moderate to severe, and we have a gene therapy that could potentially restore it to normal or normal to mild. Are you willing to carry the risk of surgery, right? Because the potential streak could injure permanently your hearing. And so that is where it becomes a little tricky. And so at Regeneron, we're really looking into the impact of the surgery itself. For example, materials of the catheter, depth of the catheter, perfusion velocity, vector of the catheter. All of these variables we think are extremely important. So we want to make sure to tell those parents, look, we have developed the technology, the surgical ability to perfuse the inner ear without ever causing any harm. It's very different than a cochlear implant, even a soft insertion, what we call soft insertion, right? You will have this huge electrode going through your inner ear. And so we're trying to develop the most minimally invasive way that we can convince our parents of patients that, hey, we have a technique, the likelihood of risk is very low, and we would recommend it for the mild to moderate. But I think you're right that the mild to moderates, the moderate to severe, are in the next 5 to 10 years. The profound GJB2s, those are more straightforward, right? We're going to probably treat them as profound otoferlin patients.
Thank you, Dr. Sharon. We have about 1 more minute and a couple more questions, and so I just want to allow those who need to sign up for Tumor Board at 7:30 to do so, and just kind of say thank you so much, Dr. Corrales, for being here and presenting. For those that are able to stay on, we'll have a couple more questions. Dr. Jolie Cheng asked, when Omar Akil and Lustig did the gene therapy studies in mice at UCSF, they believe there was a developmental age window to get the most benefit. Have you seen this, or do you suspect this?
Yeah, I remember working with Omar, actually. He came down to Stanford and showed me the technique of, doing the gene therapy trial. And Omar was amazing. He was a brilliant postdoc. So I could tell you that we thought that there was a critical window. But from all the other companies reporting, especially the groups from Shanghai, we think that this is not the case anymore, right? They've had really good hearing restoration, even after a decade of not receiving any sound stimulus in that ear. So when we think about a critical window, we're not using this information like a cochlear implant, where we're trying to get them earlier and earlier for the brain plasticity, for the auditory perception, etc. That is not the case for this. Now, the years to come are going to tell us if an injection at 12 months of age or 5 years of age makes a difference, right? But so far, the hearing restoration has been seen in older patients as well. How much improvement and how useful and functional that is, time will tell with testing.
Thank you so much, Dr. Chang, for that question. Dr. Vivi Young had a quick shout out. Happy new lunar year, new lunar year to all, and then wanted to know what puppies are called in Britain. And then Dr. Lim wanted to ask about, can you comment on long-term hearing trajectory anticipated into adulthood and then older age?
Yeah, I don't know what they're called in England, to be honest. I should have asked that. Long term, we will have to see. You know, moms, it's usually the mom who's well vested into this, are usually saying, is this a one and done deal? And the best we can say is like, at least over a year, it's been. And who knows what's going to happen? We're not sure if we're going to have to repeat every 5 years the surgical approach, or every 10 years, or if this is one and done. We really don't know the answer to that yet. And I don't think anyone knows that yet. I think the longest group that has looked is the Shanghai group in Fudan with Eli. And so far, they're reporting now probably close to 2 years data. And so far, it's been robust in their hands.
Thank you so much. We have Dr. Song Chang.
Eduardo, good
How's
morning.
it going?
Good to see you. So I actually have a couple of questions. Very interesting presentation. Actually, I'll jump to the one which your last comment kind of made me think about. You said that we don't think that there is a critical window now, but you then alluded to the neuroplasticity. So I would be interested to know if the window is preserved because the contralateral ear has been implanted, and so the brain has some acoustic stimulus. Or are you saying that these patients can be completely, acoustically naive, like no sound at all, and have a prolonged period of deafness, uh, then subsequently get gene therapy and do well with that? That would be very interesting.
No. So, yeah, there's a little bit of misunderstanding there. There is no question that we believe that the earlier we get the gene therapy, the better. It's better to implant a 12-month than a 5-year-old who hasn't had any stimulus, right, for the auditory pathway, right? That's one thing. What I was mentioning is that if a patient has had cochlear implant on one side, which is a lot of patients right now that we're perfusing, they have had some sort of, stimulation throughout their auditory cortex, pathway, inner ear, etc. But what we used to think back then of that ear not working for the next 15 to 20 years has broken a lot of our mental schemes, right? We don't, at least for the otopharyngeal population. So in what we've been seeing, I am not discarding that ear anymore as we would for a cochlear implant, for example. But there's
Right.
no question that we think that the earlier, the better it is, just to get sound stimulus into the auditory cortex.
And then follow-up question from that is that, say, a patient who has had deafness in that one ear for a long period of time, how helpful is your otoacoustic emission in predicting outcomes in recovery?
And we're looking at the data right now, Son. Great question. Because
Yeah.
this will be a beautiful test, right? To give us a sense if we categorize the distortion products and give them a prognostic indicator for the family or for even the patient at 15 or 16, 17 years of age. And so
Yeah.
we're looking at that data right now. One thing that I want to say, and I don't know if anyone has picked up on this, but we've been talking a lot about, ABR for testing, distortion product for testing, but pure turn average for follow-up, right? However, bears, or ABRs has been a little more tricky to pick up in these patients. Even though we have patients telling us, oh my God, it's amazing. I feel that I can hear so much better of my gene therapy. Somehow the ABRs are not as robust as we wanted them. So there's something to say about that, right? Time will tell how predictive these tests are from a testing side, but to an outcome side as well. And so we're looking at all this data right now.
Yeah. And the last kind of follow-up question to that is that, with otopharin, it's really nice that we have this neurophysiological marker of function, the otoacoustic. With GJB, are those same tests as useful?
Yeah, I would say that we would have to submit a criteria package of how to diagnose them. But there's no question that it's going to be very important to have the ABR, the distortion product, et cetera, for testing of these of GJB2 patients. No question about it.
Okay. Thank you, Eduardo.
Yeah, great to see
Always
you.
great to see you.
Absolutely.
Thank you, Dr. Cheng. Dr. Dylan Chen, did you have one other quick question? I saw your hand raised. If not, I have another question for Dr. Corrales before we wrap up.
Oh, no, I'm good.
Okay, I apologize. Yeah. My question, Dr. Corrales, is I wanted to ask about that moment or that in your talk where you talked about how when the patients, I guess, who've turned the contralateral cochlear implant off, seem to be able to create speech that's more natural. And we kind of alluded to this with kind of these imperfect measures for speech, but I'm curious if you guys have a postulation of how otoferlin is able to mimic hearing better than a CI, and what aspects of that is it doing that better than a CI, and then what measures do we have or do we need to create to measure the impact?
It's a great question, Michael. And I can tell you this is all anecdotal. And I don't think we would get any data if the mom did not have an older sibling with bilateral cochlear implant, right? So her experience, the family's experience with one sibling with bilateral cochlear implantation and having a second younger sibling with cochlear implant on one side and gene therapy on the other, it's all been anecdotal, right? There hasn't been any how would you test the natural perception of sound, right? It is more mom and dad's view that whenever she's not wearing her implant and only using the gene therapy, her voice sounds more natural to them. And it's hard to quantify, but very interesting. I could tell you when I heard that, it really makes you think about how we're changing our view of gene therapy and cochlear implants.
Do you kind of have a thought of why that necessarily is, other than kind of imitating something that's more physiologic? And do we have measures that can pick up on that and really kind of expand how we understand, responses to different interventions for hearing loss?
Yeah. The only reason I can think of is that if you're putting this protein back in, everything else that the body has is theirs. It's part of it, right? With a cochlear implant, you're bypassing everything and stimulating the spiral ganglion immediately, right? So there's got to be some fine tuning happening within the organ of Corti that maybe the patients are perceiving it more natural, right? But I mean, that's just speculation.
Hey, Eduardo,
Yeah.
there would be, I mean, a fairly straightforward way of measuring this would be to do language environment recordings, so to do Lena recordings with that kid using either the CI or the with and without the CI, and you can just do analysis of the vocalizations.
That is currently
Have you
being done
considered
right
that?
now, Dylan.
All right, great. We'll be excited to see what that shows.
I agree. I think this, these 24 months ahead are going to be impressive to see what is happening, not just, from our study, but from all studies. It'd be good to see what everyone is doing and presenting the data. It's just a phenomenal time.
Okay, well, if we have no further questions, thank you so much, Dr. Corrales. We really appreciated your talk and your insights, and very exciting, very thought-provoking. Probably the most questions we've had for Grand Rounds, and so we appreciate you leaving the time, getting that engagement. So thank you so much. We really appreciate it, and thank you to Nikki and Song, who helps inspire and help connect me to you in the first place. So thank you very much.
Awesome. Thanks for the invitation. Nikki, Song, Michael, and thanks to everyone for joining.
Thanks, Eduardo. Appreciate it,
pleasure.
Charles. I appreciate it.
Thank
Congrats.
you.